When I started this process, I knew absolutely nothing about HIV and AIDS, and I certainly knew nothing about how the U.S. government was responding to it. As we've gotten more focused on data particularly, my colleagues in CDC here have been central to my ability to understand what matters, what's important, to be able to boil things down to the kinds of sound bites that you sometimes need when you're doing health diplomacy. I've had to do several things in the last year, specifically with respect to the acceleration plan. We needed an understanding from the government here ahead of time that they were going to pick up the cost of the additional people who will be put on treatment as a result of the accelerated testing, and that they would do it in a sustainable way. In other words, we'll get the people identified and on treatment, but then the government has to pick up the cost into the future. And that involved, among other things, negotiating an actual agreement with the Ministry of Health in which they acknowledged what costs were going to be generated and accepted that the government would be taking over responsibility for them. But we've also had an opportunity to engage the government on operationally specific issues. The biggest one that was brought to me initially by the CDC team here had to do with how the government was procuring ARVs. The Namibian government, because again it's handling 2/3 of the AIDS response countrywide, the Namibian government procures virtually all of its own ARVs. And they've done it traditionally through a program that used the domestic public procurement process. The domestic public procurement process introduced a lot of middlemen, basically, into the overall procurement. And what that meant is that the Namibian government, as of this year, was paying somewhere between 2 and 5 times the international price for some of the basic antiretroviral drugs that are used. That information was first brought to me by my CDC team. They had done an analysis of what the government was paying, and then they compared it to what some of the other governments in the region, in some of the other high-burden countries in Southern Africa, were paying. And they put together a nice table for me that showed the comparison. The comparison, I have to say, was pretty stark. The prices here were just much, much higher. It was convenient that all of this happened in the same time frame as the negotiation on the acceleration plan, because the government, in accepting that it would take over payment for the new patients on treatment after our 2-year acceleration, was casting about trying to figure out how they were going to do that. And we were able to demonstrate to them that if they changed how they were procuring and at what price they were procuring basic ARVs, that they would save enough money to be able to add thousands of additional patients with no additional cost. The Minister of Health happened to be going to the United States. He was going to go to Atlanta and meet with the CDC leadership. And so we did a kind of 1-2 punch thing where I let the CDC leadership raise it with him, having raised it with his permanent secretary, the senior civil servant in the ministry before that. And then while that was going on, I took the same information and went to the finance minister and showed him what the fiscal impact of their procurement decisions was. And the combination was quite effective, I have to say. It got their attention in a big way, to the extent that, well, several things happened. The permanent secretary who was responsible for the procurements ended up being replaced. The man that came in to replace him had near the top of his list finding a new way to procure ARVs. And they are now procuring those ARVs in a new way. And that's all basically as a result of health diplomacy. Our CDC team here is embedded in the Ministry of Health, and it has been for more than 10 years. I mean, they're physically co-located with the ministry leadership. That has allowed them over time to develop the kind of personal relationships that make interaction both at an operational level but also at a senior managerial level much more productive. The CDC team probably has the most ready access to national level data on what's going on here. The CDC team works directly with the people at the ministry who are responsible for the national response. They work with them in their planning, they work with them as they adjust their strategies, they work with them in setting their goals. And it's that interface between the numbers and the activities on the one hand and the embassy and its diplomatic operations on the other. That's the connection. I rely on the CDC director particularly to be a regular present member of the country teams. I look to him not just to say everything is fine at the Ministry of Health this week, but to actually tell us about what they're doing and what issues they're following and what problems they've picked up on. I really think the key to our success over the last couple of years has been that CDC has been a full player on a team. And one thing that we've been doing for the last year or so that I think has been quite effective is that there is I think it's weekly now, kind of public affairs communications strategizing group that has a CDC rep and a USAID rep and a Peace Corps rep and the embassy PAO who kind of rides herd on the whole thing. And that is the way we both keep in touch with activities out in the field that we might get PR mileage out of, and then plan around them so that we can make sure we get maximum advantage out of them. But it also allows the people in each of the agencies and offices who do public affairs to be singing from the same sheet of music. We need to present a public face that shows that it is a single institution. And this coordinating body with the public affairs officers has helped a lot in that respect.